Guys, my name's Danny. Is it starting now, Karishma?
Yeah.
Great. My name's Danny, I'm one of the fifth year students. So today we're just going to be going through AKI and CKD. Quite big topics in a way. So there's going to be an emphasis more on AKI. It's the more common presentation and one that you're going to be picking up more clinically. Chronic kidney disease, they've usually got a diagnosis. All right. So this is what we're going to be going through today with an emphasis upon causes, how patients present, investigations and management. Appreciate with it being Zoom, it's quite hard to make it interactive. So there's not going to be too much interaction. But if you do have any questions, please pop up on the chat, please shout out. Okay, so we're just going to start with function of the kidney. I think personally, if you can remember the function, especially in relation to the kidney, because it's got so many different functions, it's easy to understand the signs and symptoms of dysfunction. So the kidney, it's all about balance. So water balance, blood pressure control, acid-base balance, and electrolyte homeostasis. It's got a detoxification function, so removal of urea, the byproduct of protein metabolism. And about 75% of drugs are excreted renally. So it's really important in prescribing, maybe altering doses in renal dysfunction. And it's got a hormonal element, which I always used to forget. So you've got erythropoietin, which is for stimulating your red blood cell synthesis and activation of vitamin D for calcium homeostasis. All right, and this slide just kind of like emphasizes the kidney's role. It's a support function, and it is all about balance and harmony, hence this picture, and just kind of maintaining health. This is the definition of AKI. So it's an acute decline in kidney function leading to a rise in serum creatinine or a fall in urine output. And this second line is really key. So when it's dysfunction in disease, you're going to lose control of fluid, electrolyte, and acid-base balance, which will give rise to your symptoms. Okay, and this is the kidney disease improving global outcome classification. I wouldn't get too hung up on these numbers, but it's good to know that you can classify AKI in terms of stages. And the numbers to remember really are that a rise in serum creatinine of 26 micromoles over 2 days is one of the kind of like baseline tests, or a drop in urine output of 0.5 mils per kg per hour. Got a little clinical tip though. I was actually speaking to a friend who's a doctor, and I kind of ran through this presentation, and she said, well, she doesn't really remember any of this. She just thinks if there's a urea above 8 or creatinine above 100, she's concerned. So I suppose it's useful to have a knowledge of the KDIGO, but clinically, those are the numbers you're going to be concerned with. In terms of creatinine, creatinine is a proxy for a glomerular filtration rate. And it's important to remember you actually get a 50% reduction in EGFR before you see that rise in creatinine. So that's a huge, you're getting huge loss of renal function before you actually see any change in the creatinine. So just to emphasize that point, you want to pick these patients up early and quickly and just save any potential organ damage, because by the time you pick them up, you've probably already lost over 50% function. Okay, so this is just some stats and epidemiology. So AKI does complicate 15% of hospital admissions, and it represents up to 20% emergency admissions. It's got high morbidity and mortality, with 20% inpatient presenting with AKI, far greater in the ITU setting. And I suppose when you reflect upon the functions of the kidney, maintaining that homeostasis, if that's out of function, it will lead on to knock-on organ function, dysfunction even. Okay, so our risk factors. So it does affect the older population more. So your general patients you'll see will be older. Pre-existing kidney disease, diabetes is a big one. Any kind of sepsis or infection, Don't forget your nephrotoxic drugs, iatrogenic causes like contrast media for CT. And pregnancy is one that I often forget is an independent risk factor for kidney damage and emergency surgery. Okay, so you can break AKI down into kind of 3 causes: pre-renal, renal, post-renal. I'm sure you're all familiar with that. In an OSCE situation, if you're asked, cause of AKI, and you start to say, well, there's pre-renal causes, renal causes, and post-renal causes, you've already passed the station. The examiner's kind of confident in your abilities. Pre-renal is by far the highest, represents by far the highest kind of prevalence of acute kidney injury. And if someone asks you, okay, what causes pre-renal kidney injury? The one-line answer to that is hypovolemia of any cause. So it's all about blood flow. So the kidney is a highly vascular organ. Any drop in blood flow to it causes damage. So it's as simple as that. However, causes of pre-renal, there are many causes of pre-renal. Now, I'm quite a visual learner, so the only way I can remember them is via a cartoon. So we'll just run through it, and hopefully it'll help you remember the pre-renal causes, because they are quite hard to kind of like keep in your head. So this is Sydney the kidney, and he represents our journey on pre-renal AKI. So he's in a raft and he's hit a rock. So this represents volume depletion. So severe vomiting, hyperemesis, diarrhea, and reduced fluid intake. These are the patients who are at risk of a kidney injury, and you want to be getting fluids into them. Okay, he's fallen in now, his boat's sunk, and he's taken on water. So this represents Oedematous state. So you've got heart failure, cirrhosis, and Nephritic Syndrome, which can cause Oedematous state. The thing to think about here is it's just that loss of oncotic pressure in cirrhosis and Nephrotic Syndrome. So intravascularly, you're seeing a shift of fluid to third spaces. You're getting less intravascular volume and less perfusion of the kidney. So it's all about perfusion. And going back to that one-line answer, cause of pre-renal AKI, it's hypoperfusion of any cause. Heart failure, again, you're getting fluid shifts and peripheral edema, so you're getting less intravascular, and you're getting less stroke volume from the heart, so you're getting less perfusion of the organ. Okay, shock. So the definition of shock is circulatory failure, which leads to cellular and tissue hypoxia and causes end organ damage. Sydney's gone over a waterfall. He's in shock. So you've got your distributive causes, your hypovolemic causes, your bleed and your burns. Cardiogenic causes of shock, and obstructive shock. And again, it's all about perfusion. So in obstructive shock, you've got a massive PE, you've got pressure on the heart, it's not able to pump as effectively, you're not perfusing your kidney. All right, and Sydney's been washed up onto a rock, and he's abusing NSAIDs and ACE inhibitors for whatever reason. So this is just remembering that drugs is a key cause of pre-renal. NSAIDs can cause intrinsic renal AKI as well, but it's a key cause of pre-renal. And you've got your abdominal aortic and renal artery stenosis. And again, just to emphasize, pre-renal cause, it's hypoperfusion of any cause. This slide just represents how NSAIDs and ACE inhibitors affect renal function. So you've got prostaglandins, which help to dilate the afferent arteriole. NSAIDs inhibit that. You're going to get afferent constriction, you're going to get less blood flow. So again, it's about blood flow. You're getting less blood flow into the glomerulus, and you're getting a drop in renal function. Conversely, you've got in bilateral renal artery stenosis, ACE inhibitors or angiotensin receptor blockers stop vasoconstrictions. You get dilatation of the afferent arteriole, and again, reduced EGFR. So acute tubular necrosis is an intrinsic cause, but pre-renal injury can cause intrinsic injury. And because the kidney is so metabolically active, you're getting reduced blood flow will quickly damage the kidney. In this, in acute tubular necrosis, you get necrotic tubular cells that can slough off and actually cause an obstructive cause. So from pre-renal, you've got a renal cause and then a post-renal cause. All right, and this is Intrinsic AKI, so intrarenal cause. Again, I'm quite visual, so in my head, intrinsic, I've just got an image of a nephron in my mind. So start at the top, you start the glomerulus, which Genevieve's going to be running through in a bit more detail, but basically the glomerulus is not acting and filtering effectively, and it's causing reduction in kidney function. Tubular damage, so you've got your drugs, your nephrotoxins, methotrexate in high dose, you need to be careful. Gentamicin, you need to monitor urinary and renal function. And myoglobin and rhabdomyolysis damages the tubule, and cause of rhabdo is long lie and crush injury. With your interstitial nephritis, that's actually an inflammatory process which is happening within kind of the medulla of the kidney. And this is a type 1 or type 4 hypersensitivity reaction, and it's just stopping the tubule act effectively. You've got those ion transporters and it just stops that action and it causes kidney injury that way. NSAIDs cause pre-renal but can cause intrinsic renal as well. Okay, and we've got our post-renal causes. It's getting a bit easier. It's pretty straightforward. So Mr. Taylor, the trauma surgeon at Aintree, kind of spoke me through a way to think about tubes and causes. Again, in an OSCE situation, someone asked, well, post-renal causes, if you said, well, there's extraluminal, luminal and intraluminal causes, and just think about the urethra as it's a lumen, it's a tube. So extraluminal compression, you've got BPH or a tumour. Intraluminal, so an issue with the lumen itself, you're thinking strictures, fibrosis, and intraluminal, you're thinking a renal calculi. Again, just a bit of an OSCE tip. If you know, you're asked for kind of like anything with a tube, you can break it down by extraluminal, luminal, intraluminal. Okay, so the presentation of AKI is often asymptomatic until later on. And generally, the symptoms reflect the underlying cause. So in pre-renal, it's those signs of hypovolemia. So dehydration, tachycardia, cool extremities, and just looking underloaded, you're going to be fluid deplete. With renal, you've got those more intrinsic symptoms, which again, Genevieve will be going through. But it's like rash, arthralgia, bruising. And post-renal, you're getting those post-renal obstructive symptoms like renal colic, a distended bladder. And along the bottom, don't forget fluid overload. That's more for renal and post-renal. But it can actually be a cause of pulmonary edema. I think people think heart failure with pulmonary edema, but it can actually, AKI in extreme can cause peripheral and pulmonary edema. So this is something I've only really picked up this year. It's probably more of a 5th year thing to be concerned with, but it can be an OSCE station and it's fluid assessment. So you've got a patient who's presented in A&E, and they've got a reduction in urine, and you want to and a rise in creatinine, and you want to assess the fluid status before, which is going to guide how you manage treatments. It's really the question you want to answer is: are they hypervolemic? Have they got too? Are they fluid overloaded? Are they hypovolemic? Are they dehydrated? They need fluid. So you can ask your key questions: how have they been eating and drinking in the last 2 days? Some observations: your heart rate, blood pressure. Urine output can be difficult, but you can get that from the patient. You know, I've not been going to the toilet as frequently. If they've got a catheter in place, that's helpful. So you start at the mouth. Are they dry? Is the tongue dry? Calf pre-fill above 4 seconds, well above 2 seconds. You know, they're hypovolemic. You can check skin turgor, which is you pinch it and it just takes a long time to kind of like go back into shape. It's a sign of dehydration. And you want to check JVP, which if it's, you know, right up towards the neck, you know, they're overloaded. Really important to listen to the chest if you're going to give fluids, because if they've got crepitations and they might be fluid overloaded, they might have pulmonary edema. The risk is you give them fluids and you send them into flash pulmonary edema, which is life-threatening. So you generally want a chest X-ray as well. You want to listen to heart sounds, and you want to check the sacral edema in the legs. Now that's quite a lot to remember. So if you did 3 things in your fluid assessment, you'd want to look at your patient's membranes, listen to the chest for any pulmonary edema, and check the legs for any peripheral edema. And this is just, it's as simple as that in terms of managing the hyper or hypovolemia. So in hypo, you're going to give fluids. In hyper, you're going to fluid restrict and give a diuretic. Okay, so just back into AKI, a bit more focus on the AKI and specific investigations you do. You want to do urine E, and again, just emphasize that clinical tip. The numbers, urea above 8, creatinine above 100, you know, you're going to be concerned. You want to do urine dip, and that's to any protein urea. You're seeing that, well, the nephron's not functioning properly, you're leaking protein. And is the hematuria and proteinuria is an intrinsic cause. First line imaging is ultrasound scan. And what you're looking for is 3 things really. Is the kidney dilated? Is the hydronephrosis? That's indicative of an obstructive cause. Have they got small kidneys? That's more suggestive of CKD. And if there's a normal looking kidney with positive serology, it suggests those rarer intrinsic causes like good pastures and all that kind of stuff. You want to check liver function for Hepatorenal syndrome. And Hepatorenal syndrome is a pre-renal cause of AKI. So again, you're losing that intravascular volume. You're not producing the proteins, the albumin, you're losing oncotic pressure. So it's a pre-renal cause. And you want to check the platelets just for those kind of blood problems like hemolytic uremic syndrome or thrombotic thrombocytopenia purpura. And you've got your intrinsic investigations. And I spent some time in the renal unit at Royal, and that comes up as a panel. So doctors just request it as a panel. So you don't need to remember every single kind of like autoantibody, but as Genevieve will go through glomerulonephritis, they are good for exam questions. Okay, so the approach in terms of managing a patient presented with AKI, it's generally for supportive care, and you do want to rule out sepsis, you want to stop the nephrotoxic drugs, you want to do a fluid assessment as we've just spoken through, and your main query is pulmonary edema, are they really overloaded? You want to look at urgently the electrolytes because hyperkalemia is life-threatening. You want to treat actively hypovolemia and hypervolemia. If there's any metabolic acidosis, you want to treat that. And then moving on, once you've got them a bit more stable, you want to do fluid balance. You want to do daily monitoring for creatinine to see if the pitch is improving, and potassium. And last line of defense is dialysis if the patient isn't getting any better. So you guys have probably seen this before. Stop the damn drugs for nephrotoxic drugs. So you've got D, diuretics, and digoxin. So I group them together. You've got your ACE inhibitors, your ARBs, and your aminoglycosides, metformin, and NSAIDs, and don't forget lithium. So these are drugs you want to do a really thorough kind of prescription review and just stop any of those nephrotoxic drugs. All right, Sydney's back. So pre-renal AKI management. Generally, you just want to, it's quite straightforward. You want to correct the volume depletion. You want to stop any of those nephrotoxic drugs. You want to treat the underlying causes, whether, you know, if it's dehydration fluids, shock or sepsis, and the cardiac causes. And you want to monitor the patients very closely. And I get this, speaking to my friend who's a doctor, she'd forgotten all these causes of AKI, because in her mind, it's always a dry patient. It's a pre-renal and it's a dry patient. So in clinical practice, that's by far the most common presentation. Okay, for your intrinsic AKI, you want to stop your nephrotoxic drugs again, and you want to refer for a biopsy and specialist treatment. Post-renal management. Generally, it's resolving that obstruction, so catheters can help if it's blocked by a cancer tumour. Nephrostomy can be helpful to get flow back. And if it's stones, you want urological interventions like lithotripsy and surgery. All right, so we're going back really to the start, and AKI, it just stops the kidney's ability to can keep the balance that the kidney's all about. So you get lots of fluid, electrolyte, and acid-base balance, and an inability to detoxify. So you get uremic symptoms, you get uremia building up. So you've got your management of hyperkalemia there, fluid overload, metabolic acidosis, if it's not septic, bicarbonate infusion can help resolve that. And in your uremic presentations, if you've got uremic pericarditis, it's going to be patient with chest pain with an AKI or chronic kidney disease, and those muffled heart sounds and encephalopathy, you can have a reduced GCS or confusion or odd behavior, and treatment for that is dialysis. Okay, and finally for AKI, I've seen exam questions on this, so indications for dialysis. So it's AEIOU, so acidosis less than 7.1. Electrolytes, if you've managed the hyperkalemia, but it's still above 6.5, dialyze. Patients are taking overdoses of paracetamol, lithium, and you can't resolve that through management. Dialyze. And if they're fluid overload and not responding to diuretics, dialyzing them can relieve that pulmonary edema. And again, if you've got uremia and it's that the management for uremia, the management for uremic symptoms in a patient is dialysis. All right, so catch your breath, and we're just going to move on to CKD. All right, so this is our definition of CKD. So you've got, is there any questions actually on AKI so far? No, it's fine. So CKD, so you've got, it's an abnormal structure or function. Remember that it's got to be over 3 months to be diagnostic. And I think you guys have all seen this in CCT. It's good to have a knowledge of this, just so you can categorize what stage a patient's at. And I think it's if you're G5, that's when you need dialysis. This is the EGFR clock, and it's just helpful to remember what kind of stage from the EGFR they're going to be at. So you can kind of, in an OSCE situation, you might get a question, you know, they've got, you know, EGFR less than 15, what stage they are? 5. Okay, this is probably the most important slide for CKD, and it's just understanding the cause of it. Diabetes and hypertension is by far the highest cause. You can get polycystic kidney disease and glomerulonephritis. So just in terms of diabetes and hypertension, just thinking about the pathophysiology, you're getting damage of the glomerulus, you're getting increased hydrostatic pressure and breaking of that filtering ability. So you're inside the nephron now, and you're getting kind of proteins and macromolecules within the nephron, which causes damage, and it causes a cascade of reactions. So you get inflammation, you get oxidative stress, cellular damage, and you get more collagen synthesis. So if you can remember what happens in CKD, it's so much easier to just remember kind of how patients present. So kidneys are spongy, but you're getting collagen, they're getting denser, they're getting harder, they're getting fibrosed, they're getting smaller, they're not filtering as effectively. So that's why it's over time, it's getting worse and worse and worse. And you're seeing that drop in kidney function as the kidneys literally become kind of hard and small. And this is some imaging and just showing those unusual looking kidneys. They're just harder. They've got, you know, they've got radio opaqueness to them. So they're getting kind of like deposits within them, and they're just not going to filter as effectively. So again, just emphasizing the risk factors. If you remember anything from the CKD talk, just remember hypertension and diabetes, and that increased pressure from hypertension within the glomerulus, or diabetes, glycosylated proteins disrupting its filtrate, the filter, and damaging it and allowing macromolecules through. Family history, it's important to ask the patients about any family history and congenital kidney disorders. Good question to ask patients is about any subarachnoid hemorrhage in the family or themselves. Okay, so just moving on to our signs and symptoms of CKD. So you've got itch can be a symptom, which I personally didn't appreciate. Loss of appetite and nausea. You're getting muscle cramps because you're getting that electrolyte imbalance. Peripheral neuropathy from uremia. You get hypertension, pallor. So your signs is going to be oliguria, so reduced urine output, swollen ankles, swollen feet. Uremia, so if there's any kind of behavior change in GCS. And again, restless leg syndrome is a sign of uremia, so that it's having a neurological impact. All right, so just thinking about kind of exams and MCQs, this is a typical history of CKD. So we've got a 54-year-old gentleman with a 10-year history of diabetes and hypertension, so our two risk factors. He's got complications with diabetic retinopathy and peripheral neuropathy, so he's not a very well-controlled diabetic from that. And he's presented to his GP and he's complaining of fatigue and weight gain. They're key symptoms of CKD. And he's got a weight gain over 3 months. That's fluid overload. He's got some intermittent nausea and anorexia. And he stated that his legs are more swollen. So again, that fluid retention. And on physical examination, he's overweight. He's got high blood pressure, and he's got cotton wool patches and microaneurysm bilaterally. So again, just emphasizing he's really poorly controlled diabetic. Yeah, so if you can just remember, this is how patients present for CKD. It's going to be helpful for exams. And it is quite an insidious presentation, and it can be a bit non-specific. All right, so in CKD, key investigations are from bedside to special tests. Just emphasizing the most important ones, so your blood test, your urea, and electrolytes, creatinine, and your glomerular filtration rate. Just remembering that ultrasound is very good at diagnosing CKD, because you're going to see those small fibrosed kidneys with the collagen production. Okay, moving on to management. So CKD is not really a cure, it's just about trying to slow down. So conservative management, you want patients to maintain a healthy weight, exercise and dietary advice. You want to avoid phosphates, milk and cheese and stuff like that, and meat. Sodium, you want to reduce your blood pressure, so you want to keep sodium low. You want to avoid potassium, like crisps, foods high in potassium, just to prevent yourself tipping into hypokalemia. So a key complication of CKD is hyperkalemia. And it's speaking to patients, it is quite hard because they've got to reduce the drinks as well, so they can be quite thirsty, but they're only allowed certain amounts of fluid per day. It's a pretty nasty disease. In terms of management, I say it's all about slowing disease progression. So treating hypertension. So there's some criteria for when you'd start NSAIDs and angiotensin receptor blockers, which is covered in CCT. The important thing to remember is stop meds if there's a 30% increase in serum creatinine, or fall in eGFR of 25%, or you see a rise in potassium. So I think this is where I used to get confused, because it's like, well, ACE inhibitors are bad for kidneys, right? Because we've spoken about AKI, but they are actually renoprotective in terms of reducing hypertension. So it's just making that distinction really clear in your mind. And you've got, when you start your ACE inhibitors, you've got your monitoring requirements. You want to check your eGFR, creatinine, and potassium prior to starting your antihypertensives. You get a baseline, and then 1 to 2 weeks later. Okay, so you want to slow disease progression. to just emphasize on that point. So good glycemic control is key, and you're targeting a HbA1c less than 53. And this is just about in chronic kidney disease when to refer to nephrology. So when you've got an EGFR less than 30, so that's CKD 4 and below. Albumin creatinine ratio less than 70, sorry, greater than 70. Or you see an acceleration of disease, you see a rise in a fall in EGFR 15–25%. And going back to those causes, it's diabetes and hypertension, which are the primary causes. So if they're on 4 antihypertensives or more and they're still poorly controlled, you want help, you want nephrology. And again, just thinking about the function of the kidney, again, it's all about balance, it's all about detoxification and the hormonal elements. So you've got hypertension. So that's a key complication, because the kidney, it's receiving less blood flow, it stimulates the RAS system, actually makes you retain more. So it's kind of like a negative loop where you just get worse and worse hypertension, more kidney damage, the RAS is activated more. Anemia, so you've seen that fall in erythropoietin and red blood cell production. Don't forget uremic disease from it, so you're getting your pericarditis and uremic encephalopathy, hyperkalemia. So just remember that kidneys homeostasis of potassium, they kick out a lot of potassium, so if it's not working, you're going to retain. And especially if you're using kind of like potassium sparing diuretics, so they're contraindicated as well. So like your spironolactone. You actually get gut issues as well, so you get uremic gastritis, pretty unpleasant. And you can get bone disease, you can get renal osteodystrophy just because of its hormonal function. So you're not getting that conversion of vitamin D into its active form, vitamin D3. So you can get pathological fractures. So it's just important for those to be managed. And this is how they're managed. So just a bit of a summary. So you want to control your hypertension with antihypertensives. If you're anemic, you can give erythropoietin stimulating agent. And you want to control your cardiovascular disease. Uremia, if they've got uremia, you want to dialyze them. Restless legs, benzodiazepines can be effective. And for your renal osteodystrophy, you want to get your phosphate binders. You want to stop that breakdown of bone. You want to stop your osteoclasts breaking down bone. And you can give vitamin D to support that. All right, so we've come to the end. These are some the Oxford Handbook's got some really useful flow diagrams that simplify the approach, which has informed this talk, and Pulse Notes have some excellent resources as well. I think you do have to pay £5 a month to get access to some of them. And just to finish off, we've got 5 questions. So this is the only bit of participation I need now, is either put some stuff on the chat or shout out if you're feeling brave. It's question 1. We've got a 62-year-old gentleman. He's presented with shortness of breath in the early hours of the morning. He's got a past medical history of hypertension. He's on amlodipine and indapamide and doxazosin. He failed a trial of ramipril 1 year earlier due to a 40% rise in creatinine. On examination, he's got high blood pressure and he's tachycardic. His chest x-ray is showing pulmonary edema, and his ECG, there's no abnormalities, no elevated troponins. And his echocardiogram, he's got a normal ejection fraction. It's his 2nd episode in 2 months. So what is the most likely diagnosis in this case? Anyone want to shout out? All right, don't worry. So we've got, it's renal artery stenosis. So he failed his ramipril trial. So it's shown he has got, if he's having a rise in ramipril, sorry, if he's having a rise in creatinine following ramipril, it's in, you know, in your MCQ, think renal artery stenosis. All right, question 2. So we've got a 35-year-old female admitted to the ED, and she's been diagnosed with AKI, and which of the following is not an urgent indication for dialysis? Just looking at the chart, sorry. E, so people are saying E, I've got an E, I've got a D. All right, so on this one, it's amlodipine. So again, this is just remembering DAM, stop the DAM drugs. So diclofenac is an NSAID, so you want to stop that. So N for DAM. Digoxin, you want to stop. Furosemide is an ACE inhibitor. Sorry, furosemide is a diuretic, which you want to stop. Although if the fluid overload, you can use it in metformin. So amlodipine is one that's safe to continue. Question 4, can you name 3 risk factors of CKD? Oh, did I skip question 2? Let's have a look. Sorry, skip question 3. I did skip question 2, I'm sorry. I'm sorry. Yeah, so on this one, what's not an urgent indication for dialysis? People were right, it was E. Sorry, I've jumped ahead. Okay, so we've kind of spoken through this one, so this was amlodipine. And question 4, this is, so back to where we were, so 3 risk factors for CKD. So if people just want to say in the chat, just any 3 risk factors for CKD. Yeah. Diabetes, hypertension, just remember that. And I remember Dr. Chan, I don't know if anyone's got Dr. Chan CTT, but he asked me that question, and I don't think I knew it. So, you know that. And finally, we've got question 5, just going back to kind of whether they're hyper or hypovolemic. So 5 important clinical signs when carrying out a fluid status assessment. So if you can just remember the top 3 really, if you can remember our top 3. Yeah, mucous membranes, peripheral edema. And what if you think about giving fluids? One more. Yeah, so you want to make sure they've not got pulmonary edema, because it's that risk of putting them into flash pulmonary edema. And that's the end of my bit. So thanks for listening. Thanks for taking the time today to listen to, and if you want to take a 5-minute break, what time is it now? So you want to come?
I think you should all be able to see my screen now, so I hope that's okay. So my name's Genevieve. I'm also one of the 5th years. So I'm today covering the fun topic of nephrotic and nephritic syndromes. So I'll start off here. So we're just essentially going to be covering nephrotic and nephritic syndrome, the glomerulonephritis, and then we're also going to talk very briefly about acute tubular necrosis as well. So I think glomerulonephritis can end up being quite complicated, and you can get bogged down in a lot of the details. So I've really tried to kind of simplify it as much as possible and just do basically what you need to know, the common presentations and the essential management, which is basically all you're kind of going to be asked about in the MCQs. So to start with, nephrotic syndrome. The best way I can think of to remember nephrotic syndrome is to focus on the O's, so nephrotic, and that is proteinuria, hypoalbuminemia, and edema. So if you just remember that those words have an O in them, it helps you remember that they make up a nephrotic syndrome. And the most sort of common causes of a nephrotic syndrome are these. So that's minimal change glomerulonephritis, diabetic nephropathy, focal segmental glomerulonephritis, amyloidosis, and membranous glomerulonephritis. So I'm not really going to be covering diabetic nephropathy and amyloidosis because you can get so bogged down in just the glomerulonephritis. I thought I'd focus on those. the most. So investigating nephrotic syndrome. The main investigations that you want to think about doing is a urine dipstick, and then you send that off for a microscopy and a protein electrophoresis. You also want to do a 24-hour urine collection, and this allows for a sort of a protein creatinine ratio. And so you can either do that over 24 hours, or you can do sort of just one sample and a random check on that. You always do your standard bloods, of course, full blood count, LFTs, CRP, the standard ones, but with particular focus on your UNEs and your EGFR especially. Lipids and HbA1c are quite important because a lot of the sort of nephrotic syndromes actually causes dyslipidemia. So that's quite a useful finding to notice if your patient has sort of dyslipidemia and some kidney dysfunction. An autoimmune screen. So what you'll find is glomerulonephritis is often linked to autoimmune diseases. So getting these kind of sort of done will help find what the underlying cause could be of the actual presentation. You always want to consider hepatitis B and C serology because they can be linked with nephropathy as well. And then never forget to do a bit of renal imaging as well, because a lot of these kind of syndromes can present similarly to other causes of AKI, which Danny has already covered. But finally, the sort of only way you're going to get an official diagnosis of what kind of glomerulonephritis it is through a renal biopsy. And that will give the sort of cellular changes that you will find in each particular glomerulonephritis. So how do you actually manage a nephrotic syndrome? I thought I'd cover the basic management, and then we'll kind of go over the individual management, which is quite similar, to be honest. So you want to restrict their sodium intake. So you don't want to overload them with normal saline fluids, and you don't want them to be eating ready solid crisps and everything like that. You want to keep them on a low sodium diet. You want to give them a diuretic, which can often feel a bit unusual when you're thinking about an AKI and like kidney dysfunction, but with a glomerulonephritis, they're often very, very edematous. So you do just want to get that fluid off them as quickly as possible. You want to consider anticoagulation, and you want to keep them as active as possible, because one of the main complications of a nephrotic syndrome is a thromboembolism. So if they're quite high risk anyway, you want to give them some anticoagulation. ACE inhibitors, very useful for proteinuria. So if they've got massive amounts of proteinuria, make sure they're on an ACE inhibitor, as that can really help manage it. And most importantly, you treat the cause. So if it's an autoimmune disease, you want to treat the autoimmune disease. So the first glomerulonephritis I'm going to cover is minimal change. So this is described, the sort of pathophysiology is reversible podocyte dysfunction, which sounds a bit silly, and a lot of these kind of terms are quite complicated, but these are the sort of buzzwords that will often come up in MCQs. So if in the back of your mind you can remember some of these kind of common renal biopsy changes, that's quite useful for recognising the cases. It's the most common glomerulonephritis in children, and they typically present with edema around the face. So they'll come in and their parents will say they've gotten really swollen, and it's especially around the face. So it's less likely, in your legs, and as you would sort of expect in older patients, it's often around the face. The common causes, as with any kind of kidney dysfunction, it's often just idiopathic and they don't really know why. Also commonly NSAIDs, glandular fever, and then you've got to also consider some underlying cancers like Hodgkin's lymphoma. And also on renal biopsy, you will see fused podocytes, which is the podocyte dysfunction cause. And the treatment there is high-dose corticosteroids, and you might consider in severe cases cyclophosphamide. So the next nephrotic syndrome is Membranous GN. So this is the most common glomerulonephritis in adults. So whereas minimal change is in children, membranous is in adults, and it's quite a common cause of end-stage renal failure. On renal biopsy, you'd expect to see a spike and dome appearance, are just one of those other buzzwords. And the main causes, as expected, idiopathic, NSAIDs, but also autoimmune disease are quite a common underlying factor. So again, typical management as per the sort of usual management for nephrotic syndromes, you want to give them an ACE inhibitor and possibly some immunosuppression like a steroid and cyclophosphamide if it's quite a severe case. But this has quite a variable outlook, so it's the rule of thirds. So 1/3 of these patients recover completely, 1/3 of these patients remain in sort of quite severe renal failure, but with just proteinuria, and then 1/3 just go complete end-stage renal failure and end up needing dialysis and possibly a renal transplant. And this is the one what you really need to consider anticoagulating, because 5% of patients do end up with a renal vein thrombosis. So the other nephrotic syndrome we're going to talk about is focal segmental glomerulosclerosis. So this causes nephrotic syndrome, but it can also cause CKD in young adults. So it tends to present in sort of late teens and early 20s. And it's often sort of associated with these underlying causes: sickle cell disease, HIV, and IV drug users. So if you have quite a young person with these kind of risk factors, that's what you'd be thinking of at that point. So on renal biopsy, you see sclerosis, which is in the name, and then podocyte foot effacement. And the main sort of treatment for this is just steroids. So now I'm going to talk about nephritic syndrome. So nephritic syndrome, I will then focus on the eyes. So with nephrotic, focus on the O's in the sort of underlying pathophysiology. In nephritic, you focus on the eyes. So these eyes are hematuria, oliguria, and hypertension, which doesn't quite work, but you can see an eye there. So if you have a patient with those, you're thinking it's more of a nephritic syndrome. And the sort of main glomerulonephritis causes of nephritic syndrome are IgA nephropathy, rapidly progressive glomerulonephritis, and Alport syndrome. But just to confuse you, you can actually have some other features of nephrotic syndrome but the overlying diagnosis is a nephritic syndrome. So IgA nephropathy. This is also known as Berger's disease. So sometimes in exam questions and things like that, you might see it referred to as Berger's disease, just to kind of confuse you. And this usually presents with macroscopic, so visible hematuria, and often it can present with HSP, sort of like rash. So you will get like a vasculitic rash on the buttocks and the legs, and it's usually associated with a 2 to 3 day history of an upper respiratory tract infection or a gastrointestinal upset. So that's the important thing. With IgA nephropathy, you're thinking it's only 2 to 3 days after an infection, and it's usually in young males and children. So you might get teenagers, but it's often in sort of like around 10 years old and that sort of age group. The main sort of risk factors and causes associated is just sort of like HSP, vasculitis, but also you want to consider some other sort of autoimmune underlying factors, so like celiac, psoriasis, and other seronegative spondylosis. But also cirrhosis, usually alcoholic cirrhosis, can cause IgA nephropathy in slightly older men. And the mainstay for this condition is just you want to control the blood pressure with ACE inhibitors, and you might consider steroids if it's quite a severe case, so if they've got massive amounts of macroscopic hematuria and their blood pressure is rocketing. The next is rapidly progressive glomerulonephritis, And this is one of the sort of most severe glomerulonephritis that you'll see. So it's basically rapid loss of renal function with formation of epithelial crescents and macrophage aggregation. And this is the one that you will notice red cell casts on microscopy. And the main causes are Goodpasture's syndrome, Wagner's granulomatosis, and other autoimmune diseases. So the Goodpasture's and Wagner's granulomatosis, I'm not going to go into too much detail because they're often vasculitis, and that'll probably be covered in a later revision session for you guys. But the main clinical features you'll find are massive amounts of hemoptysis, and that's due to a pulmonary hemorrhage, and that's in Goodpasture's syndrome, and therefore they'd have anti-GBM positive on their autoimmune screen. So that's why autoimmune screen in sort of nephrotic and nephritic syndromes are so important, because this can really tell you what might be going on. And then the other presentation is with epistaxis and sinusitis, and you get that more typically in Wagner's granulomatosis. So you get nephropathy, epistaxis, and sinusitis. The mainstay for management in this is a little bit different. You still want to immunosuppress them, so with steroids and cyclophosphamide, but you might end up considering a plasma exchange in these kind of patients. Alport syndrome. So Alport syndrome is a genetic disease, so it's an X-linked dominant disease, and it's basically a collagen deformity that causes an abnormal glomerular membrane, and usually it presents in childhood. So if you've gotten quite a sort of older teenager or in the 20s, it's much less likely to get Alport syndrome because you'd have noticed the clinical features much younger. So the main clinical features in this sort of picture is sensorineural hearing loss, sort of renal failure at quite a young age, and when you dip the urine, they tend to have microscopic hematuria, so that's non-visible, but when you dip it, you get blood. And then retinitis pigmentosa is the other sort of typical clinical feature. So you tend to get a bit of a mix of these. So you will have a patient who has a history of sort of hearing loss on top of sort of worsening renal failure. And eventually this usually requires a renal transplant, but unfortunately this can actually fail because the syndrome, it carries on, and it can end up creating sort of like Goodpasture's like syndrome, as we sort of talked about on the previous page. Okay, so just as a sort of main refresher of the main nephrotic versus nephritic syndromes, and then always the awkward mix that cover both. So in nephrotic, you have minimal change, focal, segmental, and membranous, and the sort of main sort of almost bullet points that I wanted to get across of the kind of triggers that you should think of when you think of these diseases are minimal change. You've got to think, okay, it's in children, you treat them with steroids. In membranous, it's most common nephrotic syndrome and glomerulonephritis in adults. It's also associated with CKD, and you want to immunosuppress them. In focal segmental, a bit more of an age gap, so you can sort of see that in quite a few different kinds of patients, also CKD and also steroids. So it's nephrotic, they're the most common, glomerulonephritis, minimal change, and membranous. In nephritic, IgA nephropathy, you're probably going to get either an HSP rash or visible hematuria only days after inerty. And then you have rapidly progressive, which is more severe cause, so suddenly getting real steep decline in renal function with red cell casts, and that's usually anti-GBM, Goodpasture's, and Wagner's. Alport syndrome is the sort of weird eye things, because I can never remember retinitis pigmentosa as a term unless I've just done this revision. So I always think, okay, if they've got eye defects, hair defects, hearing defects, and it's young children, it's probably Alport syndrome. And then, just to confuse matters, you can have a mixed nephrotic and nephritic, and these are the two main ones, post-streptococcal and membrano-proliferative, and I'll cover that now. So post-streptococcal is the one they like to confuse you with between IgA and then post-strep. So post-streptococcal is a mix because it presents with both massive proteinuria, but also hematuria, and that can be macroscopic or microscopic, hypertension and edema. So as you can see, it's got the main sort of factors of nephrotic with proteinuria and edema, but also nephritic with hematuria and hypertension. It can be any one of those kind of group, but typically it might be sort of a mixture. But the main point of post-streptococcal is it's usually at least a week after a streptococcal infection. So that could be otitis media, it could be just a throat infection, so they've had a really sore throat, cellulitis, and it's usually in children. But the main difference between IgA and post-strep is that post-strep is 7 to 14 days after, whereas IgA is almost immediately. And on immunofluorescence, the typical feature is starry sky, and that's the kind of term they like using. However, post-strep actually has a relatively good outcome, and it's mostly just supportive management. So it usually resolves completely spontaneously, just with needing some sort of supportive measures like antihypertensives, fluid restriction, and then some diuretics to help with the edema. And the antihypertensives tend to be ACE inhibitors again for the proteinuria. Membrano-Proliferative. So this is quite a poor prognosis disease again, unfortunately. So it can basically present with any of the mixed features of nephrotic and nephritic. So it's very, very variable in its presentation. So it can have a mixture of hypertension with edema or hypoalbuminemia. So it's not necessarily as clear cut as some of the others. And there's 3 different types of membrano-proliferative, and it's quite complicated, so I didn't want to get too bogged down in all the details and end up quite confusing. So type 1 is hepatitis C related, and the sort of typical features are on sort of renal cell biopsy and immunofluorescence are immune deposits that sort of look like a tram track. Type 2 is factor H deficient, and that's usually the sort of underlying cause. And what you'll see is partial lipodystrophy and dense deposits on the biopsy. And then in type 3, this is also hepatitis B and C related. I didn't want to go into too much details because I think membrano-proliferative is quite an unusual one, and it's also very, very complicated. And typically, they tend to go for more of the more common and manageable presentations to ask you about. But the management is just aspirin, ACE inhibitor, and then again immunosuppression with some steroids. So I'm just going to sort of quickly cover acute interstitial nephritis, which Danny sort of touched on in his presentation, to do with sort of AKI and CKD as a cause. And acute interstitial nephritis is essentially a hypersensitivity reaction, and it's usually either due to some nephrotoxic drugs or a systemic sort of inflammatory. So it might be an autoimmune disease that's causing systemic inflammation, or an underlying infected disease and sepsis. So these are the main sort of causes that you see. So in drugs, disease and infection. And it's quite often the sort of expected culprits in drugs, NSAIDs, diuretics, and then allopurinol, penicillin. And as with anything, this is the frustrating thing with a lot of nephrology, is that the treatment for nephrotic syndrome, like diuretics, can end up causing acute interstitial nephritis. So management, for one thing, is always going to hurt the kidneys in another way. The disease, it typically tends to be lupus, often can be sarcoidosis as well. And the main sort of culprits behind infection are it's usually streptococcal infections, but it can also be staph, and you've also got to rule out brucella. So these are the main clinical features of an acute interstitial nephritis. So usually it does cause an AKI, and the main sort of feature of that is just oliguria. So they're just not passing any sort of urine. And they often have hypertension, and they might have a bit of a rash, and they genuinely just feel, the sort of term general malaise is a good one. They will just feel really rubbish. And then this is usually, they will have an inflammatory cell infiltrate and edema on their renal sort of cell biopsies. So the cells are all sort of massively edematous, and the sterile pyuria. So that's like on urine dip, and then on microscopy, you'll see white cells, but it's sterile. So there's no sort of bacterial sort of identifier in that urine sample. And you'll also see white cell casts. So whereas earlier we talked about red cell casts, you'll see white cell casts in acute interstitial nephritis. As with any sort of kidney disease, you want to stop the cause. So if you think they're on one of their sort of high risk drugs, you want to stop it and stop it immediately. If you think that it's because they've got an underlying infection, you want to get on top of that, give them antibiotics, and sort of get treating that, do your sepsis 6 protocol. And if it's an underlying inflammatory disease, you want to do the direct treatment for that. So if they've got an autoimmune disease like lupus, you want to sort of step up the treatment and management of that. And as with a lot of these nephrotic and nephritic syndromes, you want to give them some prednisolone as well to dampen down their immune response. So I thought I'd do just some quick questions. So I'll give you sort of 20 seconds to have a think. And if you are feeling brave and you want to add the answers to the chat, please do. But don't worry if you're not entirely sure, because they are some of them are quite difficult on purpose, just to kind of get you used to the buzzwords that the MCQs will use. So a 6-year-old boy presents to the emergency department with blood in his urine. He has a high blood pressure. And he's just recovered from an upper respiratory tract infection around 3 days ago. What is the most likely cause of his presentation? So if you have a think and want to write down your answers, put them in the chat. We'll go through them after I've done each of the questions. Right, and the next question, it's a 23-year-old young man complaining of swelling in his face and legs to his GP. His urine dipstick comes back +++ for protein, so his GP schedules a number of blood tests and sends a urine sample for analysis. What's the most likely underlying diagnosis here? So if you just have a think, pop your answers on the chat, and then we can go through them again after I've talked through the other questions. Question 3. A 35-year-old woman presents to A&E with a 5-day history of hemoptysis. On her blood test, she's found to have a suddenly worsening renal function. Her doctor orders a renal biopsy and an autoimmune screen. What antibodies are most likely to come back positive? And the next one, a 12-year-old girl presents with her mum complaining of a headache, feeling generally unwell and passing only small volumes of really dark urine. Her mum says she thinks she's gone quite puffy in her face and her face is swollen. Her urine dipstick is positive for blood and protein. She's she has just recovered from an upper respiratory tract infection 10 days ago. So what is the most likely cause here? I can see all the right answers coming through in the chat, so well done, but I'll talk through it in a minute. Some routine bloods of a 25-year-old man with sickle cell disease come back showing a steady decline in his EGFR as well as a consistently low albumin. He's diagnosed with CKD, but on referral to the nephrology team, they decide to obtain a renal cell biopsy. What would be the typical finding in this likely diagnosis? This one is really hard. I thought I'd throw in the sort of buzzwords for the renal cell biopsies and immunofluorescence findings, just to try and kind of get those points across. So I'll go through the answers now. So that the question one, I can go back to you guys submitting your answers there. So yes, a 6-year-old boy presents to the emergency department with blood in his urine and has a high blood pressure reading. He had an upper respiratory tract infection just 3 days ago. And you're right, that's an IgA nephropathy. So here, that's clearly a nephritic syndrome with the hematuria and the high blood pressure. So although like minimal change is the most common in kids, you've got to think that is a nephrotic syndrome, so you can rule those ones out. And then in post-streptococcal glomerulonephritis, usually seen around 7 days after infection, and so this is much quicker. And then membranous glomerulonephritis is more common in adults. So the 23-year-old with protein and swelling sends his sort of samples off. What's the underlying diagnosis? This is membranous. So this one was a bit more tricky, but what you've got to think of is a nephrotic syndrome with the edema and just the protein positive urine. Minimal change is more common in children. Membranous is the most common cause in adults. So you could say, oh, it could be focal segmental in that age group, but you'd usually expect to see more of the risk factors and the history of like maybe HIV or sickle cell and things like that. And then you wouldn't want, it probably wouldn't be a UTI. You'd expect a few more different symptoms, sort of like dysuria and smelly urine, things like that. And the urine dipstick would show slightly different things. Membrano-Proliferative is more of a mixed disease, so you'd expect to see features of nephritic as well as just nephrotic. So the 35-year-old with massive hemoptysis, so the antibodies, anti-GBM, yeah, so the answers were right there in the chat. So this is probably a case of rapidly progressive glomerulonephritis, likely due to Goodpasture's syndrome with the pulmonary hemorrhage. So therefore, when you've done the antibody screen, it would be positive for anti-GBM. 12-year-old with the headache and dark urine and a bit of a puffy face. This is post-strep, which again, you guys got right on the chat. And this is because it's 10 days after her upper respiratory tract infection, which is slightly different to the early question of IgA nephropathy, because it's a much longer history. And because there's some features of both nephrotic and nephritic there, so she's a bit puffy, but she's also got some microscopic hematuria, that pushes post-strep to be most likely. And it rules out all the purely nephrotic or nephritic syndromes. And then the man presenting with CKD and also a bit of a nephrotic syndrome with the low albumin. And this is the correct answer, which I can see that you got right on the chat, and that is sclerosis and podocyte effacement. And that's because with this history, with a slightly more sort of slow and progressive history, it's probably CKD in nature. And because of the low albumin, it's suggestive of a nephrotic process as well. And therefore that's probably focal segmental glomerulonephritis. So just a kind of quick revision, spike and dome is typically membranous. The fused podocytes, typically minimal change. Starry sky appearance is usually associated with post-streptococcal, and partial lipodystrophy is usually associated with membrano-proliferative disease. So that's me done. That is all my questions there. So thank you very much for listening. I will stop sharing my screen now.
Brilliant. Thank you so much to our speakers for today. To be able to get the PowerPoints for the sessions, please can you fill in the feedback forms as well?